Good morning. Welcome to Bradford Health Services' first continuing education event for 2026. My name is Zach Ludwig. I'm the Vice President of Clinical Services and Accreditation for Bradford. I'm going to be introducing our session, facilitating some of your needs on the back end, and then we'll be closing up today in about 3 hours. I want to thank everybody who's joining us today. Bradford hosts webinars on a quarterly schedule, if you're not already aware. We do have a great year planned ahead. We have a number of engaging events, including ethics, which we'll likely be offering in the month of June. I know a number of people in the audience likely have to renew your licenses by July, so I hope that will be a value add for you. We do appreciate whenever we get our post-survey evaluations, all of the feedback you give us regarding future events you'd be interested in learning more about. So keep those proposals coming whenever you get that evaluation later today. Before I introduce today's sessions, I do want to share some important information as you're joining with us today. Happy to see all these good mornings and welcomes. Lots of people joining us from all over, it looks like. Nice to see some familiar names and all of you newcomers. You are viewing this session in our webinar format, which means that I can see you, but you can't see me. No, that's the opposite of what it is. You can see me, but I can't see you. I am engaging with you because of the chat and the Q&A. So if you'd like to drop us a message, please feel free, but you are automatically muted and your video is off. At the end of the presentation, we will take some time for discussion and questions, though keep those coming throughout the session. Our presenters may be able to answer the questions for you. If not, we will hold those to the end. Please note that you are going to receive a post-session email that's going to include a link to all the materials today. You're going to get a copy of the slides. You're going to get a link to the video recording that's going to be publicly available for this. So you can certainly review the material later on after the session. However, continuing education hours are only granted for those of you who are live and engaging in this session right now on this beautiful day in March. Today's session is eligible for 3 continuing education contact hours. Bradford Health Services providing these continuing education hours to you at no cost. Your attendance and participation today is being recorded through your login, so there is no need to put any of your name or credentials in the chat box, though, again, we're always happy to see the good mornings and letting us know where you're calling in from. After the conclusion of today's presentation, you'll also receive an email with the link to the evaluation. The link will be open for 30 days after today's webinar. You must complete the evaluation in order for you to get credit for your participation. After you complete that survey, you're going to receive your certificate within about 2 weeks via email that you used for registration. If you do not receive the certificate after 2 weeks, you can reach out to us through our events email address and inquire about that. Make sure you check your spam folder first. If you do not do the evaluation within the next 30 days, that's the only time it's going to be open for you. So if you don't do the eval, you will not get credit. So you cannot receive late evaluations for this. Please do that evaluation as soon as possible. We are going to put it in the chat towards the end of today's session. You want to grab it, go ahead and do it there. It's only going to take you about 2 minutes. Go ahead and get it done off your to-do list. If you'd rather wait for that email, certainly can do that, but I'm giving you fair warning. You got 30 days to do it. Okay, we are expecting large attendance today. We have about 570 people already in the room with us, and that's likely to keep going up. So give us a little bit of time to get those certificates processed for you, okay? If we experience any technical difficulties today, we are going to do our very best to log back in as quickly as possible. I will tell you, if you're experiencing technical issues on your end, you certainly can log off, log back on, change your machine. Just ask you to try to limit that. Don't do that multiple times if you can help it. That can help resolve your tech issues. If we are unable to resolve tech issues on our side because we have either lost a presenter or lost our feed in general, we will send an email out to all the registered participants with instructions about where we go next and whether that could be we offer partial credit or do a reschedule. We're going to knock on wood that we don't experience that today. Okay, now that we have all the housekeeping issues out of the way, I do want to introduce our session today. Very excited about today's topic, session titled Addressing Substance Use Disorder in Military and First Responder Populations. We have two presenters today. Our first speaker is Joshua Eckel, a therapist at Cornerstone of Recovery located in Louisville, Tennessee. He has a Master's of Science in Social Work from the University of Tennessee. He's committed to providing support in substance use disorder treatment and serving the veteran community. As a Navy veteran with 11 years of active duty service and currently 4 years of experience in the Navy Reserves, he brings a unique perspective to today's session, which he incorporates into his work with veterans, first responders, and their families. Our second speaker, Ms. Shelby Phillips, is a therapist at Bradford Warrior in Warrior, Alabama. Shelby is an associate licensed counselor with a Master of Science in Clinical Mental Health Counseling from Jacksonville State University. In her role at Warrior, she works at the programming track specifically focused on substance use disorder for veterans. Similar to our first speaker, Shelby is approaching this topic not only as a professional working in the field, but also as someone who has a personal connection to this population, as a family member to those who have served, as well as those who have experienced substance use disorder. Each speaker will certainly share with you more information about themselves during their respective portion of the session. It's my pleasure to turn over today's session to Mr. Joshua Eckel.
Good morning, everyone. It's a pleasure to be here, and I'm excited to be able to be here with you with this continuing education. So, a little bit about myself. I've been here at Bradford for over a year and did my internship here, and being able to transition from active duty Navy and then reserves while I was going to school. And so, a lot of my experience as a therapist and even in the Navy experience, as well as working with other veterans, will be trickled in and seasoned with some of the slides. So, that being said, the we'll go to section one. And today, of course, the goal is with the learning objectives, where you want to make sure that you guys get the information about what veterans, explain why veterans and first responders represent the high risk population, and for mental health disorders, alcohol, and of course, substance use disorders and suicide. These are all things that, of course, we see with our veteran population and being able to understand that on a deeper level. And then, of course, describe the impact in occupational trauma and service transition and psychological health, especially when service members are transitioning out of the military. It could be a very big culture shock on multiple levels, and being able to navigate that, and even in the mental health field, and that transitioning even out of sobriety or out of addiction, of course, is something that's always valuable. And then I will discuss the trauma-informed and integrated model for care for veterans and first responders. And then the last is going to be identifying evidence-based treatment interventions for trauma and substance use disorder. So. Okay. And then with the agenda today, it kind of gives us an overview of what our slides are going to be, at least for my portion. And want to highlight on, of course, the why this population is important, and especially where there's a lot of correlations and similarities of veterans and first responders, to include risk factors, and then, of course, statistics that are also similar with alcohol and substance use, as well as with suicide, with different variations. And then we want to the challenges in occupational of transition, highlight more of the service to civilian, as well as even highlight on a veteran population that is suffering through homelessness and then or being unhoused, as well as highlight on the contributing factors associated with that, to include like types of discharges. I think that's a valuable insight on, especially when we're discussing and doing our biopsychosocials with our patients, to understand that on a deeper level. We'll expand on more. And then, of course, the evidence-based treatment, highlighting more just an overview of treatment modalities, and then highlighting CPT, which is for cognitive processing therapy that the veteran or the VA uses and is one of their main modalities for treatment that we use here at Cornerstone, as well as seasoning with like schema therapy that is beneficial. Notice with population overall with alcohol and trauma, alcohol and substance use and trauma experience, but also is more of like our first responders as well. So, and then next slide. Okay, so with this is that there's a lot of misconceptions about for veterans and first responders when it comes to like that transition of actually seeking care and being able to be that navigating being able to meet them where they're at and understanding why this population is experiencing those trials and struggles that have led up to their alcohol or substance use is always important. And being able to have that rapport, that understanding, that a little bit in more knowledge about what they've experienced prior to coming to your office is always valuable and being able to meet them where they're at on a closer level. And then, of course, understanding like the cultural traits as well as the healthcare needs and as well as availabilities that a lot of times may or may not be available for, or mainly not available for those that are in the civilian population. And then for the other things, why it's so important is a lot of times when we have patients that are veterans and first responders that if you have the capability of connecting them with another veteran, that's something that is always valuable, that there's a level of relief that's associated with that, that you're able to allow them to open up and apply some of these skills in group therapy. I know at Cornerstone we used to have a veteran support group that met up in the evenings, and when we had more of additional veteran staff that were able to facilitate that, and we had a lot of good feedback about the veterans feeling a lot more open and willing and feeling like they were safe to be able to open up about some of the traumas that they usually wouldn't open up with in process group and in normal group. And so, and also that there's a level of usually veterans and first responders don't usually open up that they are veterans first responders because the either stigma to association, and that's something that if they feel a lot more open on expressing that, knowing that there's going to be questions that they're interested in sharing with their peer group that they may not get, or unwanted attention in areas that are more uncomfortable in populations that don't understand and know the trials and struggles that they've gone through. So, next slide. Okay, so with of course, why focusing on this population that, especially with consolidating veterans and first responders, that there's always a prevalence for high trauma exposure. And when we look at a lot of times veterans focus or the thought, excuse me, um, when people think of veterans, they think of military trauma or combat trauma. And a lot of times, there's even other variations of trauma that sexual trauma, even in the military, that is something that we is prevalent, but also bringing attention to that is important. And then, of course, understanding the different levels of trauma that first responders have experienced on different levels is where they can find that commonality. And then the repetitive, next one is repetitive stress environments. When you think of we'll talk about this more, but just to open it up on it, is the repetitive stress environment. You got to consider that there's usually high demand or what we call op tempo, that getting deployable ready and being able to perform at mission readiness is always one of those key stressors that can cloud and transition over into their personal lives. And a lot of times when members are transitioning out of the service, it's hard to make that adjustment that I need to apply self-care, and that there's a mission that involves me getting prioritizing myself in order to be a benefit for others as well. And same thing for with it comes to the first responders that a lot of times they may not be able to get that off time that due to um, the stress of in that community or natural disasters. And so there's just a lot of high demand that can be difficult with transitioning that, of course, alcohol and substance use has been used to numb. And then next. For cultural stigma, of course, that there's like cultural beliefs and fear about, even in the military, like the job, um, ability to maintain your job and as well as security clearance. That if I ask for help, then there's a risk for that, and even understanding that that doesn't apply when I'm out, and that I can ask for help and seek mental health, and it's not going to inhibit my ability to do my job. Um, and then last is, of course, the increased risk for PTSD and substance use and suicide. That will elaborate more in detail. Next. Okay, so with these key risk factors, we'll go into some details on several of these. And when it comes to like PTSD, that there's those that have deployed are three times more likely to experience and have PTSD symptoms, especially in the military, as well as I mentioned, even sexual trauma. And this is something that on active duty. That they take seriously, and there's annual training that goes along with that, as well as even in the reserves. And so, with these members that are struggling with this, even though they've gotten the training that of warning signs, there's that lack of empathy that sometimes can be a barrier because of the stigmas associated with that. So, carrying that over even in the civilian world, and then, of course, increasing that with the stigma of I'm not able to ask for help and in an environment that they're not comfortable with and familiar with can be a challenge. And then, of course, with statistics that show about like with Operation Enduring Freedom and Operation Iraqi Freedom, there was like 29 out of 100 the veterans that had PTSD symptoms. And then, of course, with even as we look back at Desert Storm and Vietnam, that we've gotten a lot better in the military about advocating for mental health, advocating for that mental toughness is the new term now in the military, and being able to be resilient in these areas and recognizing that and encouraging it's okay to ask for help. This is something that, when I joined in 2010, that if you express that you may have PTSD, then you couldn't deploy, or that you were labeled as damaged goods. And especially at my first command working with Marines, that it was something that the idea of Marines coming back and going to seek help at the behavioral health was always something that as a corpsman they told me, no, Doc, I'm good. I'm not gonna. I'll be. I just got to get prepped for this next deployment. I'll be fine. And then, but being mindful of that, especially transitioning for those that we're working with, um, it's okay to say, hey, you are, this is a safe environment, that this is something that you can open up with, and that you're in reinforcing the newer thought process about mental toughness. For hypervigilance, this one is that, of course, as you're sitting down with your patients and observing what they're maybe scanning. And I've had several patients that would say, "Hey, I'd rather, of course, sit near the door to be more comfortable," or even just saying, "Hey, how can I make it you feel more comfortable in this setting when we do have groups?" And allowing them to have that opportunity and that flexibility that I can make accommodations in order to feel more comfortable. So I'm not as so much on edge or scanning the room. And then we'll talk a little bit more about sleep disturbances. This is something that, of course, with stress environments and then prioritizing the mission, this is one of those things that um, can be difficult to adjust with self-care. And then the identifying those that, especially with when you're sitting down with your patients and for the veterans that are going back home that may have a suicide risk, it's important to see what is their safety plan when it comes to firearms. And especially if you've done patient safety plan, and then continuation of that is always important to assess while you're in there with them. And then, of course, incorporating that with them communicating and having those gun locks on there is always important. Um, and then for alcohol use, this one is, of course, we know is frequently used to self-medicate, manage anxiety, and even just help with sleep. A lot of times it's such a common issue that Shelby will be covering a little bit more in detail later in the presentation. That is such a common variable. If they're not getting good sleep, it's hard to even provide good therapy. So. Um, and then for relationship and family stressors, this one's a common one that, of course, we preach that having a good support system with AA and NA communities um, outside of treatment, but even with those that for veterans and first responders, recognizing that they may not have that or may have a fractured or broken family system due to the high statistics of just in general veterans. With married veterans have a 60% chance of divorce, as well as even with chronic or occupations, or you could say MOSs or military occupations that have high op tempo and are deployed on a frequent basis. 80% is what I found when it comes to divorce rate. And so that transition back and forth is always a challenge for those, especially not only the member transitioning back to a family routine, but also the family members transitioning to the service member coming back and readjusting. So when you apply that even thought process of them being in treatment for 30 to 90 days, or that their family says, "Hey, you need to focus on you right now." It could feel like you're going on a training evolution, or like you're reintegrating back into the family system, and being able to inform your patients and veterans that are returning back home after treatment is it can kind of draw that similarity that this is a transition process, and how to mentally prepare for that and be able to mentally accept those challenges as they're coming back. And then um, occupational burnout. This is another thing that is really important to stress when it comes to self-care. And a lot of times that um, the the stress of for those that say got out less than 20 years, um, 95% of them say that it's due to the unmanageable stress level, the op tempo, the toxic work environment. It's not easy in that environment, especially depending on which branch of service you're in. And so it's one of those where being able to identify that, as they're working on assignments, that this is an opportunity for them to focus on themselves and fill their cup so they can fill that cup up with for their family members. And then, of course, we talked about cultural stigma and mental health. So associated with the common belief that if I ask for help, I'm weak. So next. Okay. So when it comes to veterans, a lot of times people are like, "Hey, I know what a veteran is. It's a person that's served in the military." But I want to highlight a lot of sometimes we may have patients that um, may have served but not qualify for everything that's associated with veterans and the resources associated with that. So time and service, of course, on top of that is also what kind of discharge that we'll talk about a little later too. But in summary of this, for active duty, if you've served at least 24 months of military service on active duty, then you're qualified as a veteran. You don't need to deploy. That you've served your country and earned that title. And then for those that are reservists, though, if they've majority, or I wouldn't say majority, but there's a good portion of service members that transition to the reserves due to that the op tempo and environment was toxic, and I want to get into more of a balanced life. And speaking from a personal experience, it's difficult to balance that, but um, so we have some that are just reservists, that not saying just reservists, but more of that they join and start off their career as reservists. In order for them to be considered as veterans, that they have to be able to be on active duty orders and then go on a deployment and or complete 20 plus years of service. And then for the big things that also is important to recognize too is that there are occupations, of course, that don't are not frequently experienced or exposed to traumatic situations, specifically combat. But also understanding too that that doesn't mean that they're separated from those in a combat environment. So we may have like we call in the Navy a culinary specialist, the cook, that typically you wouldn't think that they would have to be engaged in combat. But if they were in a deployment in Afghanistan and they had improvised explosive device or IED that went off near them, then they could still have traumatic due to the occupational risk, or even there have been times where what we call like could be say cafeteria or chow hall or DFAC, that there's been attacks in there, and so I say all that to say where even though they may say, hey, I did this in the military, that there's not combat related job, that they could still be in that environment, especially what their deployment was like, and expressing that a little more information about your understanding of them as veterans. Um, you can validate the importance of them opening up about some trauma. So, um, and then we'll talk about discharge status a little bit later on. Next. Okay. So, and then when we look at first responders, that of course we have the law enforcement, firefighters, emergency medical services, and then emergency dispatchers. Um, that the statistics I noticed, especially when it comes to like PTSD, substance use, it went into law enforcement, firefighters, emergency EMS, and then even emergency dispatchers that from highest to lowest. And this one was interesting to see that where a lot of times society and I would say even American culture will focus so much on the veterans, but we're a patriotic nation, but giving the credit for making a time and making first responders feel like they're just as valued, if not more, is really important. And working with several patients that were law enforcement and firefighters, everyone's so quick to praise a veteran, but how often are we able to praise and encourage and provide highlight the strengths of those that were in law enforcement? And a lot of times that there may be hurdles in admitting and opening up in group about the struggles that they're going through. Um, and where even with one of our patients in emergency services that the they're back in an say back of an ambulance and that they're trying to cope with their own personal stressors as well as the stressors of um, saving patients' lives every day, and that they're trying to cope and to be able to reach out and say, hey, there's a support group that's willing to be present with you and accept you is a challenge, but that can be feel very isolated. Um, and then, of course, when it comes to law enforcement and firefighters, you have more of that team approach as well. Um, but it's one of those where, excuse me, that um, team approach that's also experiencing their own struggles, especially for law enforcement that um, if one patient really struggled with taking that first life, and constantly questioning himself of, did I do the right thing? Recognizing that his life was at risk and he had to fire his weapon was a big step, and it's not something that is taken lightly. Um, but understanding that this is an occupational risk. And same thing for firefighters, those that have not been able to say save a life is always a struggle. So highlighting all that is the military veterans and first responders. It's really important for us to really highlight the importance of them being in treatment and seeking the care and willing to open up and feel comfortable and safe to do so. Next. Okay, so highlighted on some of the statistics when it comes to alcohol and substance use disorder, and with, of course, the military population, it's very common for um, alcohol, of course, is a accepted and um, willing to be present and more of like a cultural norm of alcohol use, and then transitioning to it's okay for me to drink just not in moderation or hiding that while in the service. If it's not, causing my life to be unmanageable, it's okay, is what the thought process until they're of course missing work, intoxicated at work, and that it's that transition, of course, is common, but and then trying to cope with, of course, the trauma and self-medication from PTSD and other trauma related. For men, I noticed even with men that also had alcohol and substance use had 13.7%, as well as even with women with military sexual trauma was another common one of even higher was 16.5. And this is something where our veterans are trying to cope with these stressors and may use alcohol as well as even substances. And um, pain management is another one. When you think of combat-related injuries, or even just the wear and tear that the military provides or puts you through, that there's prescription medications, of course, with opiates that can also be abused when the members are outside of active duty, don't have that oversight, and that and also not being seen within the VA or even continuation of care can be a challenge. So, and then for um, overall, of course, that statistic ended up increasing to members that veterans, about 40% of their lifetime alcohol use can be very common. And so being aware of that, cannabis use is another thing, another substance that um, is has increased in use, especially with service members that are seeking care through the VA, that are um, uh, common to see amongst veteran population. Next. Okay. So when it comes to alcohol and substance use in first responders that mentioned earlier that for um, 26% for hazardous alcohol use, and then firefighters report out about similar percent with 29, as well as EMS. And that when you look at the trauma associated with like PTSD and then coping with that through alcohol use, they say roughly 1 in 3 develop PTSD, as well as the compared to like 1 in 5 in general population, highlighting the importance of considering that being able to identify and treat our patients and understand the seriousness of this is also important. So, um, next one. Okay. So, this one's a near and dear topic to the heart, um, especially when it comes to suicide. Um, that overall, that it was 22, but the statistics have jumped down to 17 to 18 percent of veterans um, that 22 per, sorry, 22 per day used to be the number, and now it's 17 to 18 veterans commit suicide per day. And this is something that is really important to recognize, to bring awareness to, and be able to identify and say, um, look for warning signs. And we'll talk about that a little bit later as well. Um, that of course, when we look at what are the contributing factors, we have, of course, PTSD, anxiety, and depression, and the even risks of previous suicide attempts as well as suicide ideations. Um, that I notice with veterans who experience trauma, there's 14% that at least had suicide attempts as well as suicidal ideations for 7%. This was something that is always you want to be aware of when you're talking with your patients, and being able to bring it back to it's understandable that you were struggling with several things at this time, and it's okay to ask for help. It's okay to not feel you are not trapped. You have a support system. Highlighting those strengths and allowing them to see that is always important when you're with your patients that have had history of suicide ideations or suicide attempts. And when you think about the um, trauma that there's issues with, or I should say, hurdles for them in seeking treatment is um, if they're in rural areas versus urban areas and access to the VA, that's something we can highlight on a little bit more later. But not having that support system, even with other veterans in the community, is always a challenge. And being able to identify and say, not only are they going to like PHP or IOP and plan on going to A and NA meetings, but what is their connection with the veteran community? This is something that's, I feel like we don't ask too much of, but to be able to have that cultural awareness, you're able to have some kind of tools in your toolbox. The VFW is an agency that, or Veterans of Foreign Wars, is a good agency, and that to kind of have that support system. American Legion is another one. There's several other organizations too that a member can identify specifically more of with their branch of service as well as military enlisted, and then being able to find that support system is something that you continue to connect those dots that they may not be able to relate with somebody or in a typical A or NA meeting, but to be able to find that connection there is one of those things that's also supportive and encouraged. So, and then with first responders, that you can see, of course, with law enforcement officers. Um, we talked a little bit about this earlier that there's a lot of stress that they're put under. Not only are they seeing and responding to very with domestic violence or hazardous areas, and putting their lives at risk, but also in positions where they may have to take a life. And being able or being able to process that from when I was talking with a first respond or a police officer, he expressed that he had care initially, but it was just short period. There was no follow-up action after that life was taken, as much as that he would have preferred and felt comfortable with. And so being able to have that support system in place allows that member to feel safe and opening up and having that connection out outside of work as well. Um, and then for there's also that stigma that's associated with law enforcement as well as firefighters and EMS that um, asking for help is shows weakness, and really stressing that with our sessions to be able to neutralize some of those bound barriers. Next. Okay, so when it comes to protective factors that reduce suicide risk, this is one of those things that as we look at like the family systems, what's that the support system look like, as well as even access to care. As we talk about like access to care when it comes to mental health resources with the VA, or even just them with continuation with medication regimen. It's so important to ensure that they have that those connection with resources. Um, as well as those resources that if they do need to talk to somebody, that they have that available. And then incorporating the family into that system as well is always important. Family therapy with veterans, because it's been a fractured system, it's always one of those things that you want to incorporate, that even though they may be in treatment away from their family, that this is something that their family can be a part of. Um, and then for strong relationships with the community, of course, we talked about with some of those, and can help combat loneliness and social isolation. Um, and being able to stress this with the family members is always important to um, express that there's a level of community that they need that may be more than just the NA or AA meetings. Um, Also, finding purpose and meaning in their jobs. You may have service members that are struggling with finding that occupational purpose in that they were a rifleman, or that their job was a mechanic, and but they're trying to apply those skills in a civilian environment can be difficult to find that sense of purpose, especially when you have a strong mission focused in the military, that now you can, the goal is, what is it that I need to prepare myself for? And bringing that back to you get to focus on yourself, your recovery, your sobriety as first and foremost. And the mission is your life. That can be helpful to connect that, especially with family members. Um, and then um, we talked a little bit about, of course, lethal means and neutralizing that with even incorporating that in the safety plan, or even like relapse prevention plan of what's it going to look like if they have firearms, how are they going to manage that? If they are in stressful situations, how are they going to communicate that with their loved ones? And having those locks and even a gun safe is always important. Um, and then the um, access to mental health care, ensuring like if they've met the criteria for VA healthcare. This is something that's, of course, important to connect to, as well as other mental health resources and physical health resources. That coping skills and resilience is always important. Um, that those reminders that you can take care of yourself, and these are the tools to help get you there. Um, and then um, talk about that. So supportive workplace culture. This is something where um, allowing that member to have that connection with the peer support. If they don't get it in their occupation, then getting that outside. They also have, if they're struggling, of course, with suicidal ideations, that there's a veterans crisis line that is a 24-hour phone call or phone service that's provided, and they just call 988 and then press 1. And they can also text to say, "Hey, I just need to talk to somebody." This is a valuable resource that a lot of times is underutilized because that they just need someone to talk to and encourage them to that it's okay to ask for help. Um, so incorporating that in the safety plan, not only of preventing them for relapse, but stressing of course when you do have those stressors that what is your strengths that you're going to be leaning on when it comes to your support system, as well as what resources you have available, as well as the family system and what they value and appreciate and are looking for when it comes to that member taking care of themselves and prioritizing their life over the mission that they may be transitioning with that mental thought process. Next. So, um, that this one's when it comes to the patient safety plan, I included this one, and this one is in Smart Care. As we're looking into like warning signs that maybe be developing, incorporating that understanding of what the veterans maybe what PTSD warning signs may be present, as well as their thoughts, images, mood, situation, behavior that they need to be aware of, and communicating that not only with their peers, but their sponsor and then family members as well. Internal coping strategies is, of course, we preach on coping skills and grounding techniques, but really, what is it that's going to be allowing them to feel relaxed? If that means that calling their sponsor and going to the VFW or incorporating what is it that they're able to apply to reduce that internal stress. Um, and then for people in social settings, providing distractions. This is something that, of course, we try to provide, who would that be that we'd reach out to? And that may be even other fellow veterans too, that working in your environment or in your agency, if there's other veterans that they may feel comfortable with and talking to, is always a valuable resource to, if they've developed that connection while they've been there, is something that's important to reflect upon. And then people that they can ask for help, of course, staff members, family members, other veterans, and then professional agencies. This one's, of course, that agencies that if they do have suicidal ideations that we're going to be referencing to, and then making that environment safe. If they've had any suicidal ideations or plans before, finding out what that looked like, and so that staff is aware, and if that means substance or that they've tried to OD before, or when it comes to maybe motor vehicle uh, trying to end their life with their vehicle, being able to ensure that their safety plan is set up so that they're safe. Next. Okay, this one's an acronym that um, we've incorporated when we do our suicidal awareness briefs in the military, and is always good. It's not something that is you have to follow to a T, but more of it gives you like that radar to say, okay, is this somebody that potentially could be suicidal or have suicidal ideations, and what are some risk factors that I can be identifying and to help and predict and anticipate that this person may be suicidal. And so, of course, when it comes to ideations, are they having those thoughts and conversations, even if they didn't express this before, but if they've feeling trapped or hopeless, that is this something that being mindful of, are they having those conversations outside of your individual sessions and in groups with others? And ensuring that staff members are kind of keeping aware and with behavioral health techs or counselors. Um, and then for substance use, of course, is a common one that we know of. And then feeling like you don't have a purpose. This is something where the strength-based theory is finding out what their purpose is and or what they see their purpose is. That could be with their connection with their higher power or connections when it comes to being a leader in their support group when it comes to the veteran population, but or even just the being the father that they may be afraid to be when it comes to having that connection because of multiple deployments that it's hard to have that family connection in there. Um, for time's sake, I'm just going to hit on a few of these. Feeling, of course, anxious is a common one that we assess, but feeling trapped. Um, that there's no other situation. This could be even financial debt, feeling trapped when it comes to um, their inability to uh, work a normal job due to physical limitations, and then even hopelessness about um, that they're not able to get over that hump of wanting to improve or willing to get over that depression. Um, and then, of course, withdrawing, anger, reckless behaviors, and then mood changes. All things to be mindful of and aware of as you guys are doing your individual assessment or sessions, as well as biopsychosocials with your patients, and even in group sessions too, is to be mindful of these things and uh, having that vigilant um, awareness when you're talking with your veterans. So, next. Okay. So this one's a big one. Challenges with occupational transition. And this one I'm excited to highlight on a lot of things with. So the um, when you're transitioning from military service over to civilian service, that there's a loss of inability and or identity in your role, and your role used to be more of I had a purpose and I served my country and I was able to deploy and perform well, and now I have job skills that don't transition well into a civilian occupation. Many of them have to go back to school or choose trades that line up closely with their occupation that can be a difficult transition, especially when they're not able to connect with folks that are um, not veterans. Um, lo lo Loss of structure and routine, that the structure and routine is very rigid. You know exactly where you're going to go, what you're going to do in training in military. And then, of course, you know that, hey, I have specific orders of how long I'm going to be here at this location, that I know that there's a deployment coming up, and this is the outline that I need to do to prep for that deployment. And being able to when you get out of the civilian world, there's no structure like that. You're told, hey, here's veteran resources at this college, but you're the one that has to really get your um, education plan set up. And a lot of these things are now in your responsibility. It can be very daunting and seen as hurdles that uh, especially where did a great job in your military service, but now you feel like you may be struggling in the civilian world because you have to also adjust your terminology, that you can't be as honest in certain areas and be more professional in certain areas. And so it can be a culture shock on many levels. And then, of course, there's the stigma around mental health. In the military that you may transition over, and if you admit that you're, or not admit, but more of share that you're a veteran, that they could be the questions, especially with PTSD, that you don't want to really bring up and people that you don't trust. And so identifying that these are hurdles that can be a challenge on many areas. Um, and then with peer support, especially in their transitioning and identifying, several colleges have the ability to provide that support group even while they're going in that transition is always helpful. But even connecting them with while they're here and seeking treatment, that there's even PHP and IOP veteran specific programs that you can associate with that. This transition doesn't have to be another transition like you did when you were transitioning out of the military. That this is something where you still have that support system set up. Next. And um, the other things to consider too is that their employment and financial stress. As they're applying for jobs, they're adjusting their resumes and being able to adjust their terminology to align well with um, the civilian world is something that's always important. And then adjusting that there may be a financial jump from what they had active duty and while they're here. And usually by the time that they've already experienced those struggles and getting back into a somewhat of a routine is and that stability financially can be a daunting task as well. Um, and increased risk for mental health and substance use. That transition is always influenced by PTSD, depression, anxiety. Um, and then with, for the most part, well, I'll just summarize on this one. Next. Okay. So, contributing factors for homelessness. Um, with our population this is where, of course, we see veterans that have um, been homeless or chronically homeless, suffering from mental illness and alcohol or substance use that have gotten to this point, and now they're obviously our patients in our rooms. And the big thing takeaways from this is understanding that there's so many contributing factors for the veterans and first responders that um, that are contributing to where they may have a lack of support from the family due to occupational um, hurdles that cause their support system to be dismantled while they were in the service, or that their alcohol or substance use got so out of hand that family members, while they were trying to cope with their trauma or mental health, that the family member wasn't present or able to be present with them anymore. And so, um, understanding that by the time we get them, we're trying to rebuild these things with that support group, with that uh, willingness to open up and be present in advocating for the mental health, continuing on with medication assisted therapy, or that they're um, prioritizing getting back on track with unemployment, with being employed. There are several agencies that work with veterans on getting them connected, and it's more of like a case manager opportunities. But while you're there with your patient, that looking into these resources, connecting them, and encouraging them to reach out and connect these dots is always important. It empowers them to say, okay, I have resources available, and this is something that um, there's hope in connecting these dots. Um, and then, of course, when we look at there's involvement with affordable lack of affordable housing, especially if they're on VA disability, and then physical health complications if they're on disability as well, and then how they transitioned out of the military. If there was any criminal justice involved, or that they if that was post or pre-separation, can also be other hurdles that can make it difficult for them. And so finding those strengths to encourage them to use them as stepping stones in the right direction. So next. Okay, so types of military discharges. These are questions to be mindful of, and just be aware when you do have a veteran that's your patient, is what kind of discharge did they have? Was it administrative discharge, where usually they're going to have access to most care when it comes to the VA, and then if it was punitive discharges, this is where of course, you have criminal actions that, and even just like dishonorable discharges, like a felony in the military, and that it can be very difficult to give access to those resources. So, as we're looking into it, of course, when you say that you have someone that is an honorable discharge, that typically they're going to have access to VA resources that include that they're going to, if they already applied for VA disability on the way out, being mindful of how much, what percentage they're getting of that, and if they've even applied, if they've gotten out and didn't apply for VA disability and they got honorable discharge, this is something that they encourage them to reach out and set up with, and that's va.gov, and just getting some contact numbers, connecting with that. A lot of times that they may have been burnt out so much that they're like, look, I don't want anything from the military. I had bad experience, but they still warrant those benefits. And then the VA home loan, that especially knowing the ins and outs of this is always helpful. And then as well as health insurance. VA healthcare, it's one that if you have chronic medical conditions, it's good to at least have that follow-up. They don't aren't able to see as quickly as many people would like, but at the same time too, that you're able to see a provider and have that oversight and continue up with blood draws and medication refills is always something that's important. For general, this one is that they've still been able to finish with they may have had issues, but not that many, that um, while on their DD-214, or that document that says what type of discharge, how long they served, um, that they may have general, or unable to re-enlist. This is one thing that several service members may want to get back into the service and struggle with doing so because they got a general discharge. But that's something that they'll have to communicate with the VA.gov and see if that may be any flexibility. And then there's a couple others like entry level separation, that if they're served less than 180 days, that's another discharge, as well as medical discharge. And due to even pre medical conditions, or conditions that have been provoked while in service and are more service related, that they may be getting that discharge. So those are things that just to be mindful of. And sometimes someone may say, "Hey, I, had went through boot camp and course in my training command, and so, but we may think that they may have access to resources, but this is one, if they've served less than 180 days, then they won't be able to get those resources. And then, of course, with bad conduct discharge, that a lot of times when you look at bad conduct discharge, you're going to have more of alcohol or drug related, or repeated failure to follow orders. And this is something that's going to be a negative mark on their DD-214. And that's going to prevent them from getting veteran benefits. This is going to be more likely with your chronic veteran homelessness, that there's some agencies out there, there are not too many, that will still work with and provide basic needs, but not like um, federal organizations like VA that can work with those that have bad conduct discharge. And then dishonorable discharge, this one is if they've had any charges like rape, murder, or even UA or unauthorized absence missing in military services. This is something that is really difficult to overcome for services that or service members that have gotten dishonorable discharge. So going through these, it's one of those things that to be mindful of so that you are able to connect them in the right resources, as well as know and say, okay, well, these resources aren't available for you, but going forward that there maybe some support that can be provided for you. And being able to connect them with the VA is something like, even if you don't want to break their hopes, still encourage them to call. And if there's any situations that they may have cases that have to be reviewed, that it's always important. And they'll also connect them with getting their DD-214. Folks that are chronically homeless or experiencing homelessness, that usually having access to that, it can be difficult, especially if they've had other stressors and situations that have happened in their lives that contributed to them numbing and coping with it with alcohol and substance use. So, next. And we talked briefly about this with like eligibility for VA healthcare and access to um, mental health services, housing assistance programs. They're ultimately lining up with whatever your patient is struggling with or that gaps, being mindful that there are resources there for them that in order for them, and when you go on the VA.gov website, that there's going to be access like for mental health or for education, for housing, for employment. There's and just to be able to talk to somebody is always helpful for them to help get them inspire that hope, get that motivation that even though the military may have been a difficult challenge for them, that they can still move forward with using or at least connecting with resources that can at least point them in the right direction. So, next. Okay. So this is where, of course, we're trying to mend all of recognizing that there's trauma-informed care and way that we can approach these situations and being mindful of the experiences that they've had with the modes of care that we're providing. So next. Okay, so when we recognize the impact and repeated occupational traumas, that getting a detailed history of what has been contributed to their PTSD symptoms, along with um, the struggles that they've had even outside of military service, to include if they've been incarcerated, if they've experienced homelessness, and that those traumas associated with that, to tread lightly in certain areas, and then being able to reemphasize the feelings of feeling safe and that they're trusted and that they can collaborate with their peers, with you, as well as feeling empowered. And then big thing is avoiding re-traumatizing in the treatment setting. A lot of times that you may see that their trauma and their PCL-5 score is high, and encourage them to go to CPT, and and they're like, I'm not comfortable with opening up on this. Being able to I always share this as when you're trying to unpack your trauma, a lot of times they haven't opened up with anybody about it. That what you're willing to unpack and willing to repack, a lot of times that it's difficult to you want to open up on all this and unload, but that could result to re-traumatizing that encourage them to feel safe in those first few sessions to avoid those situations. And then cultural competency for the military and first responders population. Being familiar with resources, being able to speak on and say, hey, I know these veterans in our agency that that they can feel like, okay, I can take a deeper breath. I can feel more comfortable in this area because I know that there's people that care, that there's a sense of unity and team that I'm able to connect to. And a lot of times, if you're able to find those strengths within the AANA community that you can connect and draw that bridge for them, can help empower them with providing that trauma-informed care. Next. And then integrating the modes of care. So, as we treat mental health and trauma and substance use simultaneously, that being mindful of how we can coordinate that, even with, as you know, when I do my bios, I'm already saying, okay, we need to talk about discharge and aftercare as well. And so, taking it one step further with our veteran population to can say, these are the resources that, from what you've told me, with the type of discharge that you had, as well as the VA disability that you may have, that you have these resources available to help with giving back in school, or help with finding a job, or help with housing. That inspires hope, because a lot of times that we subconsciously, that a lot of times we may not be able to, um, we may not know the resources for them, and so it's easy to kind of lump our veterans and first responders in the population, with our population that's non-veterans or first responders. That um, when you're able to separate that, not saying that they're special or require special treatment, but more of different treatment, different avenues, can be very encouraging for the hurdles that they're facing that may be different from others. And then always incorporating that peer support, family involvement, and then community resources. Providing those tools for them is always huge and helps build that rapport. And then the whole person recovery and long-term functioning. That allowing them to see that this is a hurdle, but it doesn't have to be the rest of their lives. That yes, they may have that they have the disease of addiction, but that doesn't have to be their identity. That they can still be a veteran and be able to overcome these things. Um, so really highlighting those is always valuable and important in many areas. So next. So with treatment interventions, that highlighting several of these, and each agency is of course different. I'm going to highlight a little bit of like what we've done here at Cornerstone, and then even with individual practice, and then what's been beneficial, what has been growing, or areas of growth that I've noticed. So when we look at like cognitive processing therapy, this is something I'll highlight more in detail for the next slide, but is something that is, if you're able to get certified, it's a free training link. Just talk with your supervisor, and then aligning that with, typically it's 6 weeks individually, but if you've had, like for us, we have two grad student trauma therapists that come 2 times a week. So you could take that, uh, I said more of that 6 week and turn it into more of a 3 week, be with the 2 sessions per week. And I'll highlight a little bit more in detail on that as well. And then for prolonged exposure therapy, this one is developing with the fears networks of trauma. And the goal is to involve activating their fear network through exposure and engaging with avoided stimuli. And then, of course, motivational interviewing. This one is our goal, of course, is that um, identifying more of that partnership and collaboration with them to express concerns, and then drive the conversation. Um, and then, of course, the gain their acceptance, and then as well as enforcing that compassion. And then the goal, of course, is the evoking that level of change, allowing them to see the importance of how that their life has become unmanageable because of this. So, and um, then, of course, trauma-informed, trauma-focused CBT, that if you're able to apply trauma, if you have several veterans, of course, in your um, in your group, that being able to identify certain areas of your CBT groups that can be more trauma focused in your groups, as well as applying that more in individual settings as well, can always be helpful. So, and next. So with CPT, cognitive processing therapy, this is something that I've enjoyed, and every time when I have a patient that's a veteran or someone that's experienced has potential PTSD, to have them fill out a PCL-5 and being able to get that first and foremost, and then assess where they score, and then being able to refer them to our CPT therapist. That way they can get the most amount of sessions earlier on. And usually in that biopsychosocial, usually having that form available for them, uh, to fill out, and knowing that they're veterans before, just to have that on my mind. And then, of course, that the goal with CPT is that identifying the trauma-related stuck points that a lot of times related to core beliefs, but specifically related to trauma. So, say for example, if there was a service member that ended up, I had one patient that accidentally took the life of a child while on deployment, and that coming back, he faced legal charges, but it was all upon an accident that he thought his life was at risk, and that feeling like that I am a monster, or I'm damaged goods, I'm not worthy to be loved. That there's with CPT, we're able to take that stuck point through an impact statement, have them fill out an impact statement of what the traumatic situation was that contributed to these PTSD symptoms, that you're able to reflect and say, okay, applying the CBT thought process of putting it on trial, I'm looking at the situations, recognize your thoughts, emotions, and behaviors, and now I'm able to apply this more in what's the likelihood in the situations that you were in this combat environment. And with this gentleman, that he was protecting his buddy, and thought it was an adult, but found out that it was a child that he took the life of. And so understanding that there was a high stress environment, that and processing through that, our ABC worksheets, to understand that this was something that you're not a horrible person because of this. And the goal with, of course, CPT is that you're restructuring their thought process through the impact statement and examining those stuck points and being able to reframe their thought process associated with emotions and that are indicated on the CPT or the PCL-5, that enhancing and better relationships, not only the belief that they have about themselves, their environment, as well as others and intimately, and that incorporating them to have a better social coping skills. And applying this thought process through the structured format in a group setting and individual setting is always very valuable. That has I've noticed that even if veterans don't complete the full 6 week session or got at least 3 or 4 sessions out of it, that seeds planted with the type of therapy that they're able to incorporate and apply, and hopefully with the VA, and encouraging and trying to connect those dots with them and continue on that group therapy or individual therapy in with CPT is always something that is very helpful for them to feel like this isn't the only opportunity for them to open up on this, that this is something that they can continue reframing their thoughts about the traumatic situation to be able to um, have more healthier thoughts about themselves, environment, and intimately. Next. And so, schema therapy, this is another one that um, there's not as much research when it comes to the veteran population, but more of course, with our population of like bipolar disorder, and then anxiety, depression, but mainly more of childhood traumas that they've engaged with that have come to light, that have contributed factors to primary or sec and then caused secondary schemas. Um, and ways of coping with the beliefs about themselves or others due to the environment that they've had. So that this is something where um, you're able to meet them where they're at. And for our agency, we have what we call Reinventing Your Life book that we'll give them initially and challenge them to complete an assessment and that identifies the primary and secondary schemas. And with our first responders, that they um, have that opportunity to reflect on what have been contributing factors that have provoked their PTSD symptoms and contributed to their alcohol and substance use that they may not have recognized before. And because it's more of a thought process that they engaged in as a survival method for as a child, and now that they're trying to cope with that as an adult. And so, of course, with um, the the primary and secondary schemas is important to reflect upon and apply with your therapy as well. That allows them to have other skills that they can relate to and even communicate that with their um, family members and even peer groups as well. A lot of times, with folks that have also struggled with different traumas, that you're able to feel like I can relate to, that they can unpack more of what has contributed to the decisions that they made while in that combat environment or while under that stressful situation that they may not have realized and associated with because it was a way of for them to survive through that childhood experience of mistrust and abuse or abandonment, and why that may be contributing to relationship issues and or codependency. And a lot of times when we're able to put a label on it, we can understand and identify and say, okay, now I know what I can work on to move forward with. That I'm able to have a better understanding about myself and as well as the world, that I don't have to frequently relate back to my childhood. I can recognize this is how it was with as a child, but also as an adult, that how I've coped with that and how I can move forward. So, next. Okay. So we're towards the end, and big things that I want you guys to take away from this is that with trauma increases the PTSD, substance use, and of course suicide risk. There's different variables and different contributing factors, risk factors that have correlated with why, of course, someone that may be coping with either physical ailments, um, trauma responses with alcohol and substance use, that they are able to reflect and be able to process that in an area that they feel like they can be heard and feel safe doing so. And then, of course, recognizing that with suicide, the risk factors associated or the warning signs associated with that, how to assess it and be able to be aware of it. And then, of course, the service to civilian transition to reflect on this in treatment and be able to identify and say that I think the slides ended up moving. Um, can we go back to the, sorry, I'm speaking on key takeaways, why it matters. Sorry. And forgive me, I jumped slides. So, um, talk about schema therapy, and then let's hone in on um, we hit on a little bit with the schema therapy with trauma, and then why it matters. Here we go. So, when it comes to the seriousness of this, reflecting on how important it is that we focus on them and that mental health and what has contributed to the alcohol and substance use and suicide risk. First responders for them experiencing significant higher rates of PTSD and depression compared to and suicide risk compared to the general population, and as well as many individuals with these professions face cumulative traumas, stigmas around help seeking, and then as well as barriers to care. Being able to reflect on these things and be able to speak on them and connect those dots for these service members so that they don't feel like suicide is their only option. That these first responders can feel like I can actually open up to a peer group and my therapist because they've taken enough care and consideration to look into these things that most therapists may not be interested in or counselors may be interested in doing. And so, and then ultimately, it's taking that extra step to reflect on showing that there's people that care for them. A lot of times that can be feel distant when you feel like you can't fit in. So, and then next. And so key takeaways. I was hitting on this earlier and got a little mixed up, but for cumulative trauma increase risk for, of course, PTSD, substance use, and suicide. Service to civilian transition can create identity and adjustment challenges, and then correlating that with even how they were able to, what they needed to work on going forward with transitioning from PHP to IOP or even in treatment, and connecting that with the family members or support system or reaching out and developing a new support system that with the AA and NA community. And a lot of times it's finding that new identity can be a challenge, but helping them connect those dots and relating it to the community that they had through the military can always be something, as well as even with the first responders population as well, is finding those commonalities and variables that allow them to see themselves as not as someone that's different, but more of that I can relate to with other folks that just have different titles but are able to connect with on due to their occupation or trauma experience. So, and then of course, integrating trauma-informed models and evidence-based care improves engagement for recovery outcomes. And then last, so of course, with call to action is our goal is to increase awareness for mental health, suicide risks for facing veterans and first responders, being able to apply the tools that were presented and identify those that could potentially have risk factors that may not be on our radar just yet. And then screen for trauma exposure, substance use, and then suicide risk is using the PCL5, the AD7, PHQ-9s, and then assessing those while applying those with your therapy. And then, of course, these understanding transition-related barriers, impact to treatment engagement, and then outcomes, and then implementing evidence-based clinical interventions. Of course, each agency's got different plans for like for us, we got CPT and then schema therapy that are extra feathers in our hat and tools, but being able to apply and say, what is it that I can do to apply and incorporate into my treatment with veterans and first responders that can be unique and different that meet them where they're at. And so ultimately, this is the last slide for myself. And so, hope with this you're able to gain a deeper understanding of the variables that veterans and first responders face and how to approach and meet them where they're at on a different level that's much deeper and that they may not be able to get anywhere else. So, thank you so much for your time, and I'll turn this over to Zach.
Great. Thank you very much, Joshua. Very informative beginning of our presentation today. We have lots more to come for you. We are going to take a 5-minute break. It is just around 10:30 Central Time. We are going to rejoin for our second section with Ms. Shelby Phillips at 10:35. Please do not leave our webinar. We are going to go dark for a moment. We will not have anything on screen for you, but just stay put, and we will come back with you in about 5 minutes. Thank you very much. Okay, everyone, that concludes our brief intermission. We will now kick off with the remaining portion of our training this morning. We will be introducing you to Miss Shelby Phillips, joining us from our Warrior, Alabama facility. She'll be taking it from here. Please keep those questions, comments coming. With time allotted at the end, we will have a few moments for some review with you. And as a reminder for what's been said in the chat, we will be sending our video recording, our slides, as well as some resources to you at the end of today's session. Shelby, thank you.
Thank you. And good morning to everyone, and thank you for joining. I am Shelby Phillips, and I have the pleasure of working with veterans and active military in the veteran residential and extended care programs at Bradford Health Services in Warrior, Alabama. First, I want to thank any active military or veterans. I noticed in the chat we have several that are here today, and also their families for your service and support that you provide our service members. Thanks for being here and the opportunity to talk about something that I am very passionate about. Today, we're exploring veteran-centered care, focusing on how to perform an intake assessment that honors unique military experiences and the relentless fight for sleep, the double-edged sword of military culture, and its deep ties to substance use disorder. My goal is to equip you with the practical tools to build stronger rapport, reduce stigma, and break substance use disorder cycles through culturally competent integrated approaches. Here we go. So by the end of the session, you will be able to confidently conduct veteran-centered intakes that uncover unique resilience and risk factors, explain sleep disturbances. I know Josh already touched a little bit on some of it. Hypervigilance, nightmares, sleep apnea, which are common in this specific population, and why basic sleep hygiene handouts often fail, plus evidence-based fixes like CBTI. Also balance military culture strengths like camaraderie and discipline against the risk like stigma and normalized drinking. And then integrate these for better substance use disorder, PTSD, and sleep outcomes. We will spend about 30 minutes on unique aspects of intake, about 20 minutes on sleep challenges and the bidirectional substance use disorder cycle, and about 15 minutes on culture, pros, cons, and the links to substance use disorder. And then we'll wrap up with about 15 minutes on integration, best practices, and takeaways, and resources also for veterans and providers. We'll have time for questions at the end, so feel free to jot them down, or you can send them in the chat. I've got it open, and I'll try and respond to any that I see come across. And we'll do our best to get them all answered, though. But let's begin with the why behind veteran-centered care. Veterans face higher rates of PTSD, depression, and anxiety. As a broad comparison, rates of PTSD when compared to civilians, veterans are 1 to 2 times more likely to carry a PTSD diagnosis, and those that have been in combat or deployed are 2 to 4 times more likely. Generalized anxiety disorder is 2 to 3 times higher in this population, and it's on an upward trend. According to the Department of Defense, mental health diagnosis among active duty rose 40% from 2019 to 2023. They often have invisible wounds or burdens that shape everything from trust to treatment adherence. A generic intake could miss this context, which would lead to assumptions or overall disengagement. Veteran-centered approaches, so asking about like branch, rank, respectively, will build rapport and trust a lot faster. It can also flag risk early. So, for example, branch-specific exposures, and I'll talk more about that in just a minute. But it opens doors to VA benefits, specialized care, and improved adherence. Recent VA and DoD emphasis is on patient-centered, shared decision-making, which is essential for co-occurring issues like sleep, substance use disorder, and I will talk more about shared decision-making later as well. There's also a lot of military-specific lingo or jargon, and there are terms and phrases specifically that I will do my best to break down as I go. All right, let's start with intake. Intake is not just paperwork or documentation. It is a lot of that, but it's also foundational. It's not just forms, but rapport building. It informs and allows for tailored treatment plans by enabling providers to better understand military cultural context. It identifies VA eligibility and priority groups, potential access to specialized programs. I know there's some specialized MST care and PTSD care and specialized veteran centers. It sharpens risk assessment, like higher mental health needs in combat branches, and can help identify service-connected conditions, reduces stigma, and increases engagement by demonstrating cultural competency, which I also like to bring up cultural humility. When I started working with veterans specifically, veterans and active military, I knew a little bit, but there's a lot to know. So just being humble enough to not just sit there and nod my head when they said something that I didn't understand, but asking questions, being genuinely curious. It shows respect for hierarchy. It turns a generic into personalized. For example, a Marine may prefer Marine over veteran. That small shift gains a big amount of trust. All right, standard screening questions. Start simple. Start with what branch. I'll break them down a little bit here. The Army is the oldest and largest branch, focused on ground-based combat operations, land defense, and large-scale maneuvers. It includes active duty soldiers, the Army Reserve, and Army National Guard. The Marine Corps is a rapid response force specializing in amphibious warfare, expeditionary operations, and combined arms combat. The Marine Corps is part of the Department of the Navy, but it operates as a separate branch. The Navy is responsible for sea-based operations, including power projection, maritime security, deterrence, and operations on, above, and below the water. It maintains the fleet and supports global presence. Air Force handles air and space superiority, aerial combat, global strike, mobility, and reconnaissance. It was established as a separate branch in 1947. Also, side note, there are aerial units to all the branches. So just because somebody is a pilot or flies, they are not necessarily Air Force. So avoid that assumption. Also, Space Force, which is the newest branch. They were established in 2019. They organize, train, and equip forces to protect U.S. interests in space, including satellite operations, space domain awareness, and support for joint military missions. It is organized under the Department of the Air Force, but operates as a separate branch, similar to how the Marine Corps functions within the Department of the Navy. And then the Coast Guard focuses on maritime safety, security, law enforcement, search and rescue, and environmental protection in U.S. waters. It falls under the Department of Homeland Security in peacetime, but can transfer to the DoD under the Navy in wartime. There are 3 ways to serve. So there's active duty, which is full-time work on a service commitment, and they are always on duty. Then there's reserves. All of the branches have a reserve. They do military part-time, which allows for full-time civilian jobs. They are activated when needed. So during the wars in Afghanistan and Iraq, units from all branches were mobilized. Army National Guard and Air National Guard, they allow for part-time service and they're utilized for state emergencies mostly, but can be mobilized nationally. Next is pay grade and rank. Simple question, answer is not so simple. So pay grades fall into three main categories. Enlisted, they are entry level up to senior non-commissioned officers, and it's E1 through E9. I know the first time I started hearing all the E's, I was like, I'm really not sure what this is, but E1 through E9. Then there are warrant officers, which are technical specialists. They're W1 through W5. And then commissioned officers, leaders and commanders, O1 through O10. The higher number is higher pay, typically longer, in more experience. The next question is, why did they join? What were their motivations? We'll go through several different motivators that you might hear on the next slide. Then, deployments and discharges. Coming up, I'll go through key details that you'll want to know. But as far as these 4 questions, these details turn a generic intake into one that's veteran-centered, recognizing that military experience varies widely and influences needs long after service ends. So, next, why did they join? Motivations vary, and they can reveal core values and resiliency. Patriotism and service, a strong sense of duty, desire to protect the country, and personal patriotism are major motivators, with many feeling a calling to defend the nation. Also, family provision or economic stability. The military offers competitive pay, comprehensive health care, housing allowances, and retirement plans. Programs like the VA home loan allow for home purchases without a down payment. The GI Bill for theirself or can be transferred to a spouse or dependent children. Many join to pay for college through the GI Bill or receive training in the military and over 200 specialties, gain skills in leadership, logistics, and technology. Life insurance for theirself and their family. There's also burial benefits. I see the chat blowing up, and I promise I'm trying to pay attention, but it's a lot. Next, family tradition. Some people may have a parent or a grandparent or mentor that served, and they have a desire to follow in the footsteps of their parents. Also, stability or escaping difficult situations, some out of necessity. So, for some, the military provides a structured environment to escape limited opportunities or difficult personal circumstances. Individuals often seek discipline, physical challenge, and character building aspects of the service, along with opportunities to travel. Some seek a sense of belonging, so being part of the brotherhood or sisterhood, and purpose that the military can provide. Ask these questions early and gently. It reveals values, maybe unmet expectations, which may seed resentments or pride, discipline, purpose, positives that you can leverage in therapy and recovery. For example, a vet joins for college, but then ends up getting combat. Were the expectations unmet? If they were, they can breed resentments towards the military, or if their family pushed them, maybe towards their family or their self, which ties to substance use disorder by way of coping. Okay. I know nobody on here signed up for a history lesson, but context helps. An era shapes worldview. World War II saw the largest surge in U.S. military history, with about 9% of the American population active duty. That included over 10 million men that were through the draft or selective service, and around 6 million men and women that voluntarily enlisted. This was the first time in U.S. history that all branches of the U.S. military actively recruited women into dedicated units. There were about 350,000 American women that served in uniform during World War II. Currently, there are less than 46,000 World War II veterans living. Vietnam. In 1968, the Army peaked at about 1.5 million, a little over 1.5 million. There is a different stigma around Vietnam. So around 70% were voluntarily enlisted, which is opposite of World War II, when around 65% were not voluntarily enlisted. But public stigma fell heavy on returning veterans, regardless of whether they were drafted or volunteered. As the war grew unpopular, many faced hostility, verbal abuse, apathy, or outright rejection. There weren't homecoming parades or heroes welcome like there was when World War II veterans returned. The anti-war movement blurred lines and often blamed soldiers for the conflict. So Vietnam vets often carry a suck it up ethos. And there are currently between 600,000 and 850,000 Vietnam veterans living. Then, following the September 11th, 2001 attacks, there was a surge in patriotic sentiment that drove up enlistments for the wars in Afghanistan and Iraq. There was around a 12% boost in the final months of 2001, with a net increase of 3 to 4% over the decade. In spite of the surge, the military remained small relative to the population at around 0.5%, serving actively at the peaks. When you look back at World War II, 9% versus 0.5% is a big difference. Current active duty alone is about 1.3 million, which is less than 0.4% of the population. If you include deployable, reserve, and guard, it's around 2.1 million, which is 0.6% of the population. So thinking about that currently versus 9% in World War II, that's a huge difference. But era shapes experiences and may conceptualize the trauma or stigma. So Vietnam vets often carry different stigma than recent conflicts. Also, there's been more awareness of mental health in recent conflicts. Branch of service. Why does it matter? So, U.S. military branches show a lot of similarities in the barriers they experience. Barriers to mental health, prevalence of conditions like PTSD, depression, anxiety, and substance use disorder, especially alcohol misuse, as well as deployment-related stressors and cultural factors. But branches are not interchangeable and can have big differences. Different branches have unique cultures, missions, training environments, deployment experiences, and exposures to stressors or hazards. I'll highlight some of the key differences. Okay. With the Army often has the highest rates of PTSD, depression, anxiety, and substance use disorder due to prolonged and frequent deployments, direct ground combat, cumulative trauma, and physical demands and injuries. They do have long, frequent deployments, which leads to increased time separated from their family and increased trauma exposure. Army experiences high readjustment and reintegration challenges with unemployment, housing, anger, and invisible injuries. Cultural barriers include stigma, which is prominent with ground combat units. Also, disciplinary substance use policies that emphasize deterrence. When it comes to prevalence, in many studies, the Army is the highest overall in mental health disorders. The Marines often have the highest intensity for many outcomes. So often highest heavy episodic drinking, possible alcohol use disorder, depression, anxiety, sorry, and PTSD, which is tied to the every Marine a rifleman ethos. Intense training and close quarter combat. Sorry, gotta take a drink of water. So, back to Marines. Their deployments are typically shorter but highly intense, around 6 to 9 months, but with frequent rotations, which leads to repeated trauma. When Marines are reintegrating, they experience struggles shifting from the warrior mindset, so troubles with emotional regulation, anger, identity conflict. They usually have poor outcomes versus the Navy and the Air Force. Yep. Barriers within the Marine subculture include having the strongest sense of stoicism or self-reliance. There's a significant stigma of mental health as weakness, which leads to low help seeking despite the higher burdens. All right, I'm going to catch up on the chat real quick and take a drink of my water. Okay, I don't see any questions right off, but moving on to the, nope, not moving on yet. Marines frequently top the list of multiple conditions, including high-risk drinking at around 25 to 33% among junior enlisted. Now, Navy. Some unique stressors to the Navy are longer, more isolated deployments, so usually 6 to 9 plus months at sea, confined living and watch schedules, limited communication with their family. This prolonged separation elevates anxiety, depression, sleep issues, and substance use disorder by using alcohol as a coping mechanism. They experience high operational stress, but lower direct combat unless they're in specialty roles. Reintegration can be more difficult due to the abrupt shift from such structured ship life. This could lead to family strain and identity shifts. The Navy's subculture is one of professionalism and self-reliance with persistent stigma. It's like fears of career repercussions or command notification, leading to underutilization of services. When it comes to prevalence, some data shows that Navy has elevated rates for depressive and personality disorders. I see, don't forget airmen. And to stay hydrated, I'm trying. Thank you for that. Air Force. So, generally, have lower rates of PTSD versus the other branches. Lower rates of severe substance use disorder, depression, anxiety. They do have shorter, more predictable deployments, more technical roles, less close combat. Their deployments typically 4 to 6 months, again, more predictable, but they can have extended TDYs, which is temp duty, remote basing, isolation in harsh environments, which do contribute to stress, sleep issues, alcohol misuse, especially air crew. Reintegration challenges include relocation stress and shifts from high stakes to routine, but still better overall outcomes. The Air Force subculture is one of professionalism and precision. There is stigma around help seeking due to impacts on flying status, clearances, but overall have lower substance use disorder rates. And then Space Force, which is the newest branch, so there is limited information, but generally align with the Air Force in most of these areas. Coast Guard, risk-wise, they have rates comparable to the larger branches for PTSD and major depressive disorder. For example, around 15% PTSD in boat station personnel. The risk is increased from life-threatening emergencies, disasters, and unpredictability with search and rescue and high-risk missions. They do have typically shorter but intense deployments, which are often domestic or maritime patrols, prolonged separation and confined conditions, high operational stress, which increases risk for anxiety, depression, sleep issues, and substance use disorder, commonly alcohol. In summary of this, the highest burdens are with Army and Marines because of the combat, ground-focused, lead to higher rates of PTSD, trauma-related substance use disorder, depression, anxiety, often 2 to 3 times the odds versus Air Force and Space Force. Navy, due to the isolation and long time at sea, and the Coast Guard, because of the high-risk emergencies and unpredictability, are just a little lower at moderate level, and then lowest in Air Force and Space Force due to less combat intensity, but still elevated due to chronic stress and precision demands. So knowing which branch they served in informs risk profiles for specific conditions. It guides referrals to specialized VA programs, vet centers, or community resources that understand branch-specific issues. Branch also influences the language the individual may prefer to be addressed by. So I know every time that I do a biopsychosocial, I ask pronoun. So I have begun to ask, what do you prefer to be referred to? Because I did make the mistake one time of calling a Marine a soldier. So Army are soldiers, Marines are Marines, Navy are sailors. So just asking, what do you prefer to be called by? Some people just prefer veteran. Some people identify less with the military than others do. So they may just not. Yeah, ouch. I saw it in the chat. Yeah, that's what I thought. So just asking and being humble. Next, rank and leadership. Often pay grade. So this is the E and the O's and the W's we were talking about earlier. Rank is not just a title. It defines their daily life. It determines where they live and reflects socioeconomic status. It shows the level of leadership and responsibility, which dictates the level of respect they can command. It reflects their education, length of military service, and how they are treated. Asking about rank during the intake also helps assess potential vulnerabilities, helps tailor interventions, and understand their worldview or authority dynamics. Research shows a clear health gradient by rank, with officers generally report better long-term health outcomes than enlisted personnel due to factors like less exposure and more control. Lower ranks, enlisted, often correlate with higher risk for chronic conditions, poor self-rated health, or mental health challenges due to factors like greater combat exposure, less control over duties, or socioeconomic differences. Leadership roles. There is leadership within every level also, but they carry the weight of everyone underneath them. So knowing that can provide insight into the pressure and responsibilities they felt every day. If they have the skills or qualities to be a leader, what resources does that translate to that can be used in the therapeutic process? Leverage those skills, resilience, decision making in therapy. And a lot of times when working with this population, you're going to be the one that has to point those out because they're going to be the last one to give themselves credit. Next, we have ASVAB and training. So, Armed Services Vocational Aptitude Battery, or the ASVAB. It is not just a test. It is the test. It determines where they'll be placed in the military. It dictates what job or career path they qualify for. Army and Marines will refer to their job as MOS, which is Military Operational Specialty, Air Force and Space Force, it's AFSC, which is Air Force Specialty Code. And then Navy and Coast Guard use rates, NEC, which is Navy Enlisted Class. So, with the ASVAB and their training, how did this affect them? Did they end up where they wanted, or were they frustrated by it? If expectations weren't met, was it their expectations or expectations of their family? Did they build or utilize resiliency skills, or did they harbor resentments against themselves or their family or the military? With specialty training and basic training, be on the lookout for trauma. This may include hazing or bullying that's sometimes interpreted as part of the culture or process and not a big deal, but it can have lasting effects, and it can be as traumatic as combat. Now, on to deployments. The number of deployments and where they served can be very valuable information. Did they go to a high combat zone, or were they stationed somewhere with constant tension, or were they stationed somewhere with no tension at all? Each deployment can provide another piece of insight into their trauma and resiliency history. Physical, mental, and moral injuries. They're not just occupational hazards. They can be life-altering experiences. And they can sometimes be invisible. TBIs, PTSD, you can't see those things. Who did they leave behind when they were deployed? Is this a source of shame or guilt, or is it a source of resiliency? And who's supporting them now? Is their family there? Do they have a connection with the VA? Are they seeking out veteran support, or are they lacking support altogether? Next is discharge and transition challenges. I know Josh went through discharge types, so I'm not going to go through that. But I will note that discharge type does dictate their relationship with the VA a lot of times. So knowing that is important. But then transition to civilian life. How was their homecoming? Was it easy? Were there unspoken expectations or disappointments? Homecoming disappointments fuel identity loss. Some examples may include the single soldier experience. So returning to no family or loved ones at the terminal, causing intense isolation while others celebrate. The failed perfect reunions. So coming home and expecting to pick up exactly where they left off, only to find that their partners or families have developed new routines. They may have left and their wife was pregnant. They may come home to a 1-year-old that doesn't know who they are. That can be devastating. Also for the children. So children's distress. Children may show anger, suffer from anxiety, or exhibit developmental regressions like bedwetting rather than joy. And that can be internalized by the veterans coming home. After the initial homecoming, how was the transition? In the military, there's structure, hierarchy, defined roles, defined purpose. Civilian life may be pretty ambiguous compared to that. Were they able to maintain a sense of purpose and identity, or were there difficulties? Some difficulties they might experience are mental health struggles, so reintegration difficulties, including feelings of anxiety, depression, lack of purpose, no place in a new routine. Veterans may feel like a stranger in their own home or struggle to adapt to civilian life. Also, underwhelming celebrations, so feeling a lack of public recognition or status. One of my guys put it this way, and I did ask permission for this quote. He said to me, "Over there, I was a badass. I carried around a machine gun all day. I was part of something. I was somebody over there. When I got back, I was nobody." Your intake should get to the heart of how the veteran handled the transition. as it's a life change and can leave them struggling to find their place in their family, in the civilian workforce, and in society. It could pave the way to high-risk behaviors like substance abuse, behavioral addictions, and high adrenaline hobbies like jumping out of airplanes regularly. Are they doing that to cope? Or are they doing it to hold on to a piece of their military life or their identity? Or all of the above? Next, we will move on to the fight for sleep. Let me check for questions real quick. Okay, I don't see any right here in the chat. Alright, why that sleep hygiene handout isn't working? We've all seen it. Most of us consistently use it. Some of us have 25 copies in the bottom right-hand drawer and the third hanging file from the front. A lot of us have seen success with it, so don't quit using it. Just know that the handout assumes civilian norms. Veterans often experience significant sleep issues, primarily due to post-traumatic stress disorder, which is prevalent among those who have served in combat or faced other military-related traumas. These sleep issues, including chronic insomnia, nightmares, and hyperarousal, which is a state of constant alertness that makes it difficult to relax and fall asleep. For instance, insomnia affects between 90 and 100% of Vietnam-era veterans with PTSD. And similar high rates are seen in those from more recent conflicts like Afghanistan and Iraq at over 93%. This fight for sleep stems from the brain's response to trauma, where the body's stress systems remain overactive, leading to fragmented or non-restorative sleeps, non-restorative rest. Other factors like traumatic brain injuries, chronic pain, or readjustment to civilian life can exacerbate these problems. Moving on to touch on hypervigilance. The body and the mind may struggle to slow down or shut off due to years of conditioning to stay awake and alert. Just imagine for a minute what it feels like to lay down in your bed. It's dark, it's cool, the room's quiet, you're essentially alone. Maybe it's clean sheet day, I don't know. For me, that's pretty relaxing. For civilians that are accustomed to this, it may be relaxing and provide a space for your mind and your body to rest. For a veteran, the same scenario may represent vulnerability and lead to heightened arousal and senses. Instead of laying down and relaxing their body and their mind may be constantly scanning for threats, and their body's just waiting for the go signal. They never feel truly at rest. This could lead to the preference to sleep with a weapon or near a weapon, which further taints the sleep environment. With a weapon in close proximity, part of their brain may register an ongoing threat. On to nightmares. Imagine knowing that every time you close your eyes or give up control of your thoughts to your subconscious, that you'll see or relive potentially the worst moments of your life. This not only affects the veteran, but their loved ones as well. Some veterans may physically act out fights or defend against enemies while they're asleep. The thought or chance of harming a loved one makes a bad sleeping experience exponentially worse. It can lead to strained relationships, isolation, and guilt. Another sleep disruptor is sleep apnea. Mainly obstructive sleep apnea is significantly more common in military members and veterans than in civilians. Sleep apnea can lead to poor quality of sleep and nightmares. Think for a minute about being asleep and your body starts to suffocate. Your adrenaline is going to kick up, and it could trigger nightmares or cause frequent awakenings. If the main cause of poor sleep is physical, all the therapeutic interventions in the world won't significantly change that. Recent studies in 2024 through 25 showed that when compared to civilians, veterans have more than twice the prevalence of sleep apnea, at around 21% diagnosed in veterans and 9% in non-veterans. Veterans are also diagnosed earlier, at around 5% 5 years earlier. In active duty personnel, diagnoses have risen sharply, over tenfold from 2005 to 2019, affecting operational preparedness and health. In specific groups, for example, those with PTSD, rates can reach between 50 and 70%. This is higher despite military personnel often being younger and less obese than civilians at baseline. So why is it higher in this population? Key reasons for the elevated rate include a combination of service-related factors, so deployment and combat exposure is strongly linked. PTSD and mental health issues is a bidirectional link. PTSD severity increases obstructive sleep apnea risk. There's a 40% higher probability per symptom increase. So comorbid rates often between 50 and 70%. Chronic stress, hyperarousal, arousal, and fragmented sleep also play roles. Traumatic brain injury, which is common in service, is associated with poor sleep and higher sleep apnea likelihood. Active duty with obstructive sleep apnea face 3 times higher TBI risk. Chronic sleep deprivation and irregular patterns from high tempo operations, shift work, austere environments, and prolonged exhaustion, which can contribute to airway issues and sleep apnea development. Some other contributors are physical injuries, chronic pain, environmental exposures like burn pits and dust, and post-service weight gain in some cases. So all these things create a perfect storm beyond typical civilian risk. Sleep apnea often remains undiagnosed or underdiagnosed in younger service members and veterans without the classic signs. So, key takeaway here is service creates unique risk. Early screening and treatment is vital, and untreated sleep apnea worsens mental and physical health and readiness. Moving on to pain. Chronic pain and injuries make it difficult to relax or get comfortable, or pretty much impossible to remain in one position for a long period of time. Chronic pain is far more common in military members and veterans than it is in civilians, and it creates a cycle that severely disrupts sleep. Chronic pain affects about 20 to 24% of the general U.S. population. Adult population. Among veterans, rates are higher. Recent analysis show around 30% in representative general population samples of veterans. In some studies or VA clinical groups, rates reach 35 to 50+% actually. Active duty service members, 31 to 44% prevalence, which is well above civilian levels. Veterans show higher severity and faster increases over time. Especially, in one study, 2002 to 2018 trends were larger rises in joint pain, low back, and any pain among veterans versus non-veterans, even after adjusting for age, sex, race, and ethnicity. And disparities are the greatest in younger and middle-aged veterans. For example, 20 to 64-year-olds often 2 to 3 times higher than the same age in civilians. So, why is it higher in this population? Service creates unique risk. This stems from service-related injuries, combat exposure, deployments, and physical demands, including training and operations that are beyond typical civilian factors. In military members and veterans, PTSD, TBI, and other mental health issues like depression and anxiety strongly amplify chronic pain, making it more severe, more persistent, and disabling. These conditions often co-occur, creating additive or multiplying effects beyond what any one factor causes alone. The pain-sleep cycle. Chronic pain and sleep problems form a bidirectional cycle in military veteran populations. Chronic pain leads to poor sleep quality, shorter duration, fragmentation, insomnia, and reduced efficiency of sleep. Poor sleep worsens pain intensity, interference, persistence, and daily functioning. Comorbidities amplify it, so PTSD, TBI, depression, and anxiety, which are very common in this group, add hyperarousal, nightmares, and further sleep disruption. Studies show sleep disturbances predict worse pain outcomes over time, while pain contributes to developing or worsening sleep issues. Overall, this cycle reduces quality of life, mental health, and daily functioning. So, takeaways and call to action. Military veterans face the perfect storm of chronic pain and sleep issues. Early screening, integrated treatment, and VA and military resources are essential to break this cycle and improve outcomes. Don't only ask if they're sleeping. Ask how they're sleeping, how long they're sleeping, why do they think they're not sleeping, what have they tried, are they having nightmares, if they are having nightmares, are they recurrent nightmares, do they follow a theme. One model to use is the 3P model of insomnia. It explains how sleep issues develop and become chronic through 3 factors. Predisposing is the first, so vulnerabilities like anxiety or genetics. Then precipitating, so stressful events triggering acute insomnia. And perpetuating, behaviors like napping or excessive time in bed that maintain the problem. Key components explained a little bit better. The first is predisposing factors or vulnerability. So these are underlying factors that make a person susceptible to developing sleep problems or insomnia. These things exist before the insomnia begins. They increase risk, but they don't cause it. Excuse me. Things like being female, older in age, or having a naturally anxious temperament. A family member, family history of sleep issues, or psychiatric disorders. Predisposing factors are elevated in military and veteran populations. So, history of trauma could be due to deployments or childhood adversity. Hypervigilance from military training, shift work, or irregular schedules during service. And higher rates of anxiety-prone traits or physiological hyperarousal. Then, precipitating factors, so the trigger. These are external, often stressful events that initiate the onset of sleeplessness. Like for civilians, it's job loss, illness, major life changes, typically. But they are frequently higher stressors in military and veteran populations. Combat exposure, deployments, which they have disrupted sleep environments, traumatic events like IED blast, loss of comrades, reintegration challenges post-deployment, so family readjustment, job transitions, physical injuries and pain. Next is perpetuating factors. So what's maintaining? These are maladaptive behaviors or habits adopted in response to poor sleep that maintain or worsen the insomnia. It turns acute insomnia into chronic episodes. They often involve well-intentioned but counterproductive coping strategies. Some examples may be spending excessive time in bed trying to catch up on sleep. I'm guilty. Napping during the day, irregular sleep schedules, and I didn't sleep all week, I'll catch up this weekend, and then you sleep all weekend. As much as we want it to help, it doesn't. Going to bed too early or staying in bed awake for long periods, it conditions the bed or the bedroom as a place of wakefulness and frustration. Caffeine use, screen time, or other habits that heighten arousal. Perpetuating factors are amplified. Veterans may develop habits like hypervigilance at night because they're staying alert for threats. Irregular routines from service. Substance use, so alcohol to go to sleep or caffeine to stay awake. Or avoidance behaviors that keep them in bed, awake, ruminating on trauma. Comorbid conditions like PTSD create vicious cycles where nightmares and hyperarousal perpetuate poor sleep, and poor sleep worsens PTSD. There are a lot of bi-directional things in here. In essence, predisposing factors set the stage, precipitating factors trigger the onset, and perpetuating factors sustain the problem, often making insomnia a self-perpetuating event even after the original trigger has resolved. What is the significance? This model highlights that while a crisis may start the insomnia, it's the behavioral and cognitive responses, or the perpetuating factors, that keep it going, making them the primary focus of CBTI, which is currently the recommended therapy by the VA and the DoD for chronic insomnia. For trauma-related sleep issues, EMDR and other trauma therapies may be a game changer. I will go through briefly some of these interventions. So, like I said, CBTI is the recommended intervention by the VA and the DoD for chronic insomnia, and it targets difficulties with initiating and or maintaining sleep. CBTI is a multi-component therapy, and it includes sleep restriction therapy, stimulus control therapy, cognitive restructuring, psychoeducation and sleep hygiene, and relaxation techniques. There is an app that you can get to through the VA website. It's a CBTI coach. I believe it is free. I'm not 100% sure, but I believe it is free for veterans to download. Next, EMDR, eye movement desensitization and reprocessing therapy, can target traumatic memories, helping patients process and move past them for better sleep. EMDR therapy provides a structured framework for addressing insomnia by targeting emotional and psychological roots, EMDR is based on the AIP model, which has 3 prongs: past, present, and future. So EMDR therapists can uncover how insomnia developed, persists, and impacts clients' lives. There are also protocols for chronic pain and nightmares. So there can be a lot of success through EMDR. If the client has sleep apnea, that should be addressed first. Therapy alone will not fix physical causes. I briefly talked about shared decision making, but shared decision making is an active, collaborative process where patients and providers work together to choose the best treatments for sleep disturbances based on clinical evidence and the individual's unique priorities, preferences, and values. So, core components of SDM for sleep is to prioritize conditions. So determine which issue, insomnia, sleep apnea, PTSD, which one is the immediate priority for the veteran. Next, review evidence-based treatment options. Maybe it's CBTI, maybe it's sleep apnea, so they need a CPAP or an Aspire implant. Defer to medical. Supplemental aids like a weighted blanket. You provide the information along with the risk, the benefits, the effectiveness, and the time commitment for each option to empower the veteran to make an informed decision. Shared decision making can improve engagement, it improves treatment adherence, and increases the veteran's overall satisfaction with their level of care. The bidirectional substance use disorder sleep cycle. The connection to substance abuse is two-way and forms a cycle. Many veterans turn to alcohol or prescription medications like opioids or benzos or illicit drugs as a form of self-medication to cope with PTSD symptoms, including insomnia and anxiety, in an attempt to numb emotions or induce sleep. For example, more than 2 in 10 veterans with PTSD also have a substance use disorder. And studies show that PTSD often precedes the onset of addiction. However, substances like alcohol can initially seem helpful, but ultimately they disrupt the sleep architecture, which leads to worse insomnia, and increased nightmares, and heightened PTSD symptoms when they discontinue the substance or when they continue the substance. This escalation can reinforce dependence as veterans may increase use to chase the temporary relief while the underlying sleep issues persist or worsen. Research indicates that veterans with both PTSD and substance use disorder are more prone to insomnia than those with either condition alone. Early screening and integrated treatments save lives and are critical for recovery. Screen for sleep difficulties, pain, and trauma in every substance use disorder evaluation. VA and military programs already have the tools. We just need to connect the dots faster. So, bottom line is when we treat sleep difficulties and we break this pain sleep cycle, we don't just fix rest. We reduce substance use disorder, we strengthen mental health, and help our service members and veterans reclaim their life. This integrated approach is one of the highest impact things we can do. All right. Now I will move on to military culture. I'm going to check real quick in the chat and see if I got anything. I don't see anything. Okay. Pros and cons of military culture. We'll start with the pros. Military culture emphasizes discipline, camaraderie, and a strong sense of purpose, which can foster personal and professional development. Some of the key advantages are a strong sense of community and belonging. Service members often form deep bonds through shared experiences, creating unique camaraderie and support network, unlike many civilian professions. This promotes teamwork, loyalty, and a professional ethic that instills pride and identity. Personal growth and leadership skills. The structure of the military encourages physical fitness, emotional resilience, and leadership training. Members gain skills like decision making under pressure, which can lead to rapid advancement and a sense of accomplishment. Purpose, discipline, and stability. Core values like honor, duty, and sacrifice provide a clear moral framework and immediate purpose. Benefits like job security, medical coverage, and retirement plans offer long-term stability, especially during economic downturns. Professional opportunities and ethos, it rewards excellence with access to training, education by way of the GI Bill, and experiences like travel or specialized skills that translate to some civilian careers. Now on to the cons of military history. While it does build resilience, military culture can also impose rigid expectations that lead to stress, isolation, health issues. Some notable drawbacks are stigma against seeking help and suppressing emotions. The warrior ethos promotes self-reliance, toughness, and suffering in silence, which discourages admitting vulnerabilities like mental health struggles. This can foster a fear of appearing weak and prevent members from accessing support. Deployments, combat exposure, and demanding routines contribute to physical and mental strain, including long-term health effects like injuries or exacerbate behaviors such as smoking and drinking. Rigid hierarchies and rules can feel oppressive. Limited autonomy and lifestyle challenges. They often can't choose their assignments. They face slow operational tempos in peacetime and deal with family disruptions from relocations or separations. The all-encompassing nature blurs work-life boundaries. Cultural rigidity and the potential for harm. So an emphasis on conformity and machismo can lead to issues like violence or unhealthy coping mechanisms, particularly in male-dominated environments. All right. Moving on to how culture connects with substance use disorder. Military culture's strengths and weaknesses create a complex relationship with substance abuse, where stressors and norms can heighten risk, while some aspects may offer protection. Substance use disorders affect about 1 in 10 veterans, which is slightly higher than civilians, with alcohol being the most common issue among active duty personnel. The way that the pros relate is the sense of community and discipline can act as protective factors. Unit cohesion and healthy coping skills taught in training may help some avoid substance use disorders by providing alternative stress outlets and a supportive environment that discourages illicit drug use through zero tolerance policies. For instance, the emphasis on fitness and purpose can promote resilience against misuse. The way that the cons of the culture relate is high stress elements like deployments, trauma, and injuries increase vulnerability to substance use as a coping mechanism. The culture of toughness and self-reliance stigmatizes help seeking, leading to untreated mental health issues like PTSD and anxiety that often co-occur with substance use. Up to 30% of Army suicides involve prior substance issues. Drinking is often normalized as part of social bonding or de-stressing, with binge drinking more common than in civilians. The culture of drinking blurs the lines between moderate use and abuse. Zero tolerance for drugs creates barriers due to fear of career repercussions, while prescription misuse, like pushing through the pain with pills, arise from the ethos of endurance. Variations do exist by branch. For example, higher rates in the Marines due to more permissive norms. All right. Reducing the barriers. Overall, while military culture builds protective bonds, its demands and stigma often exacerbate substance use risk, highlighting the need for cultural sensitivity and interventions that reduce barriers to treatment. Let's connect the dots. Intake uncovers unique history. Address sleep disorders as key substance use disorder drivers, and navigate culture for engagement. Key takeaways. Intake reveals unique history and motivations, transitions, and supports. Thoroughly investigate sleep difficulties as a driver for substance use. Culture navigation. Amplify the pros and mitigate the cons. Improve overall engagement. It's all interconnected, so addressing it holistically. This will improve outcomes and ultimately improve lives. And your call to action. This week, I will challenge you to adapt one intake question. It can be anything. What branch? What was your rank? What do you want to be called? Screen for sleep and substance use disorder together. And seek VA resources and training. I do have several resources up here. And I will check the chat too. And see if I have any questions come up before I do this. All right.
Thank you,
The
Shelby.
Veterans Mental Health Whoa.
Oh, go ahead. I thought you were finished. Go ahead.
Nope, I was going to go through resources real quick. I'll try and get through them.
Take your time.
Okay. These are actually specific to Alabama. I do have some nationwide ones in here, but these are Alabama. So, the new mental health pilot project supported by funds from the opioid settlement aim to improve awareness and access to veterans and their families. There are several places that are involved in this. On the screen, we've got Alta Point. They have veteran crisis care and treatment. Centerstone, they're offering 3,000 free therapy sessions for veterans in person or telehealth. Sojourn Counseling, offering free EMDR, CBT, and microcurrent neurofeedback services to veterans in office, and they have a mobile service unit. And then the shoulder in Daphne, they are doing some preventative outreach, and they also have residential substance use treatment. They, for this, are focusing on veterans with substance use disorder, including women, especially pregnant and parenting, and individuals involved in the criminal justice system. Also, You Will. They are offering free telehealth therapy and crisis line for vets aged 18 to 34. They're offering 6 telehealth sessions for veterans, their spouses, or partner. On the right-hand side is all of them listed. I'll leave that up for a second in case you want to scan that code at the bottom. And next, on the left-hand side, Project Welcome Home Troops. Provides safe and effective techniques for stress relief, greater health and well-being, and empowerment to improve the quality of life for returning veterans and their families. Project Welcome Home Troops is a project of the International Association for Human Values. Offers their Power Breath meditation workshop at military installations, VA hospitals, veteran centers, and communities around the United States. On the right hand side, I know we touched on this a little bit, but 988 and then press 1 is the military crisis line. It is a free confidential resource for all service members, including members of the National Guard and Reserve and veterans, even if they're not enrolled in VA benefits or health care. It has online chat options and text capabilities. The text number is 838-255. And you can look that up online, but 838-255. And the scanny thing on the left-hand side is Connect Alabama. It is a behavioral health service and treatment finder app. It provides instant access to education, information, and services related to substance use, mental health, and prevention. The app is funded through a partnership of the Alabama Department of Public Health, Alabama Department of Mental Health, and is created and managed by Vital. And then the scanny thing on the right, that's my technical term, scanny thing, is for crisis center. These centers are safe designated places where individuals in a mental health, substance use, or suicidal crisis can walk in for help. There's currently 6 locations in Alabama: Alta Point in Mobile, Caristar in Montgomery, JBS Craig Crisis Center in Birmingham, Indian Rivers and Hope Point in Tuscaloosa, Spectra Care in Dothan, and Wellstone in Huntsville. Okay. At the top, vetlinks.org. They provide services, support, and programs for veterans with PTSD and TBI. VetLinks helps veterans and their families and caregivers through the process of submitting paperwork to the VA, connecting with veteran advocacy groups, finding behavioral health services, and other resources. Bottom left, PTSD Foundation of America offers an intensive residential program at Camp Hope in Houston, Texas, providing treatment to veterans healing from combat-related PTSD. The PTSD Foundation of America also helps to raise awareness on PTSD in the military community through public events, media outlets, social media, service organizations, and churches. On the bottom right, this one's really cool. Alabama Veteran promotes camaraderie for Central Alabama veterans transitioning from the military to civilian life by offering outdoor activities, fitness, social engagement, and a network of providers. Alabama Veteran is a nonprofit organization that aims to give veterans opportunities to remain engaged and work towards reaching their full potential after the military. I looked at this one yesterday, and they have 2 events in May. One is a golf tournament, and the other one is hold on, I think I can remember this. I think it's Silky's Ruck. I did learn what that meant yesterday, so everybody that knows what that is, yeah. And on the next page, Heroes Cares at the top. They offer support for military families in the communities where they live. Heroes provides emergency financial aid, employment opportunities, and mental health care services through a network of specially trained caregivers before, during, and after deployment. And next is National Resource Directory. You guys, this has like everything in one place. Connects wounded warriors, service members, veterans and their families with national, state, and local support programs. National Resource Directory is a partnership among the Departments of Defense, Labor, and Veterans Affairs. You can search by state. You can search by dog. You can search, check that one out. It's good stuff. And I'm rushing through, sorry. Okay, next. This just came out, and you can go to the website and download this for free. It's a toolkit for engaging service members, veterans, and families, and has a wealth of information in it. Also, Psych Armor. It's a nationally recognized nonprofit. They have trainings for military culture awareness, serving members of the military connected community and anyone who wants to more effectively engage with them. They have some online courses, podcasts, webinars. They do live speaking engagements, social media. Some of it's free, some of it's not. And they offer that certification that's up right now. And they also have a partnership with the Department of Veteran Affairs and the Substance Abuse and Mental Health Service Administration, and created the Governor's Challenge Training Portal to provide military and veteran suicide prevention education and training for state and local agencies enrolled in the Governor's Challenge program. You can go to their website for more information on that if you would like. And then all these citations. And now I believe it's time for questions.
Very good. Thank you, Shelby. Sorry, I jumped in there a little prematurely.
It's okay.
Whenever you got to the resources, I'd forgotten how many resources you had to share with us. And as a reminder to everybody, all of those resources are certainly going to be captured in the PowerPoint slides that you'll be getting, as well as in the recording as well. We do, yes, have a few moments for questions. I did want to start off with a couple that came in. I'll direct this first question to Joshua, who covered access to lethal means and some of the protections in place. Can you give some feedback to our colleagues on the line with us today about any tips you have regarding navigating that, specifically whenever we're addressing it with police officers who certainly have access to weapons as part of their job. How one might navigate that if that police officer walked into your office or facility and you had a concern about needing to address the access.
Great question, Zach. So especially one thing that like VA clinics will have is gun locks. And a lot of times with those gun locks it's that extra level of safety that you and you have your guns locked up in a healthy state of mind, that you're able to have that plan, and even just communicating on here's a key, and who I'm giving that key to with a family member, loved one, so that I know where it's at, and that if that member does have any suicidal ideations, that's part of their safety plan, that they're communicating with their family members to say, hey, this is where all the guns are, and also if they have to go and find the key to unlock it, then there's a lot of questions that they're asking in that process versus grabbing a firearm that's not locked up, in a gun safe and or a gun lock that you're not thinking critically through. So those are great resources or pointers that I would recommend for that member, especially in the aftercare, if they're transitioning back and then communicating that with a family member. So
I like to call out to the family member. I think that's definitely a good suggestion there. I want to address this question to Shelby. Really appreciate it. We got a lot of great feedback on the information when you were describing some of the variances in the branches and rank. And one of the questions that came through was thinking about how we integrate that into the dynamics in group therapy. Have you found that in your work with veterans as a population that they have kind of their own opinions about who might be the better branch or the higher rank or all those things? Probably maybe like how everyone has their favorite college football team that they think is the best, and it creates these dividing lines within the subculture of the treatment community. How does one approach a group of veterans who are all coming from these different ranks and positions so that we can level set with them?
Yeah. Well, along with military culture comes a sense of crude humor. We'll say it that way. So, um, they do give each other a lot of crap, but at the end of the day, the brotherhood and the camaraderie and the being of one unit is a lot greater than any individual branch from what I've experienced. Now, yes, they do give each other a good bit of crap about it doesn't even matter. One day it could be one branch, one day it could be a different branch. But overall, they come together as a brotherhood despite the subcultures.
Sounds like something needs to be addressed head on as part of our group norms. Okay. I want to open this question up to both of you. We'll start with Joshua. This was kind of addressed in both of your respective sections. Coordination of care, very important for this population. Um, you're both representing residential treatment facilities for substance use disorder, which relies on step down through the continuum of care, whether that's internal or external. We're often relying on other resources, particularly a call out for the VA, which both of you referenced as a great resource for vets. But as was noted by many of our attendees, there can be a great reluctance for entering into next level of care, or specifically a desire to kind of bypass the VA in particular, that they've had negative experiences in the past, or there's a kind of cultural reinforcement of staying away from the VA for various reasons. Any tips you have, again, starting with Joshua, about how you overcome some of this engagement to support people along their long-term recovery journey?
So, Zach, first and foremost, the VA is a big organization that has a large hurdle to overcome, and they're doing the best they can with what they have. And at the same time, too, it has had a bad rep um, in the past, and it's always I'd say a stable resource. Now, what I would recommend too is. I think Shelby did an awesome job of connecting with local nonprofits that are veteran resource. That's one thing I'm looking back. I'm like, yeah, I wish I did that one for Tennessee. And but ultimately, though, getting familiar with your local nonprofits, that allows the members to be able to have that sense of pride with their community, and ensuring that is communicated with your aftercare coordinators. I know with our the veterans I've worked with is um, walking them over to aftercare coordinators and say, look, what veteran resource agencies for the PHP and IOP do you have that this member can get set up with that may be out of state? And some of them are very that look like five-star resorts in some ways. So, but that being said, there's a wealth of resources there that sometimes the veteran's not going to ask for that because they don't want that attention. And so advocating for them of that extra care, and then of course printing out resources to say, hey, if you're going to stay local, here's some great resources in Tennessee, or like for those in Alabama that they can follow up with is what I'd recommend.
Great. Shelby, additions from you?
It, I support what Josh says as well. At Bradford and Warrior, we have the luxury of having a case manager, which is she's the liaison between the guys here and the VA, which is the most helpful thing because I do know, and I'm sure Josh can has had personal experiences with this. The VA is a big organization, so they have a lot of things to do. So sometimes wait times and things can be a little extreme. On my end, really just kind of ensuring them that, they're in queue. We just got to be patient is the biggest thing I can do for them.
Okay, thank you for that feedback. That brings us to the conclusion of our session. I understand by reading the chat a number of folks trying to copy and paste the survey link, and it is not working. We apologize for that. Rest assured, though, you will receive the email link later on today, which will include the survey. So you will have that. Sorry, you did not have the ability to fill it out in real time. As we promised, we'll overcome that by the time we meet again. This will conclude our session for today. And please remember to be on the lookout for that evaluation link. Must be completed in the next 30 days in order for you to get a certificate. Give us a few weeks to get it into your email inbox. Only after that time, reach out to our events page in order to inquire about that. Please be on the lookout for future social media posts as well as our bradfordhealth.com events page where we publish all upcoming publicly available opportunities. On the screen here, you have the ability to connect with us, whether that's by social media or website. Please check out our website for information about our various programs, including the sites that were represented here on our call today. Again, Mr. Joshua Eckel calling in from Louisville, Tennessee, from Cornerstone of Recovery. Ms. Shelby Phillips calling in from Bradford at Warrior in Warrior, Alabama. We thank you all for your time today. Have a blessed weekend.